good morning, everyone, and thank you so much for joining us for this last webinar in our series about enhancing our capacity to support refugee mental health. My name is Sheela Subramanian. I'm a policy analyst with the Canadian Mental Health Association Ontario Division, and I'll be your moderator and host for today. While we're just waiting for people to join us for the webinar, maybe you could tell us a little bit about yourself. Use the chat box to tell us what organization you work with and which part of the province you're joining us from. And while I'm waiting for all of you to introduce yourselves, I'm just going to give you a quick tour of the webinar room. So you're already using the chat function, which is great. You'll see our presentation in the main part of the screen as well as our webcam. The other function that we're going to pull up during the session a couple times is a consultation screen. So we're going to have some chat boxes pop up, and we'll just encourage you to share your thoughts with us when we do pull those boxes up. So it looks like we've got people joining us from all across the province. We have people in Woodstock, Sarnia, York Region, Hamilton, Waterloo, Wellington, Champlain East. So I think that's CMHA in Cornwall. Nice to see you there. People in Windsor. Great. It looks like we've got people from all across the province joining us. So welcome, everyone, and thank you for spending your morning with us today. So before I introduce today's speakers, I'd just like to let you know that today's session is going to be a little bit different than our previous sessions. We really want to hear from all of you during our session today. So we're really going to encourage all of you to participate much more actively than in the past. Today's session is a bit of a consultation as well as a learning opportunity. So with that, I'd like to introduce our two guest speakers to you today. We have Uppala Chandrasekera and Deqa Farah joining us, and I'm just going to ask them to turn on their webcam. I'll help you to do that. So Uppala Chandrasekera has over 15 years of work experience in the health sector, ranging from frontline work assisting individuals and families with mental health and addictions issues to supporting mental health programming province-wide, as well as implementing the national strategy to address mental health across Canada. Currently, Uppala is the Director of Public Policy here at the Canadian Mental Health Association Ontario, where she provides leadership for the public policy work in 5 programmatic areas, including health systems development, housing, employment, and the social determinants of health, health promotion across the lifespan, criminal justice, and equity and social inclusion. Uppala also serves as the Vice Chair of the Mental Health Commission of Canada, a national organization focused on improving the mental health system and changing the attitudes and behaviors of Canadians around mental health issues. So welcome, Uppala. Thank you. So great to be here. Deqa Farah is a mental health promoter with the Fred Victor Centre. Deqa has extensive work and volunteer background in access, equity, social justice issues, anti-racism, and cultural competence and organizational change. She's a community organizer, researcher, trainer, and facilitator. Deqa has been working with refugees and immigrants for over 15 years in the areas of counseling, crisis intervention, organization and facilitation of support groups, as well as program coordination, research, planning, and evaluation, board development, program, and leadership building. She also holds a Bachelor of Arts honors degree from the University of Toronto in Environmental Studies and Sociology. Welcome, Deqa.
Thank you. Hi, everyone.
So we're going to get started by sharing our goals for today's session with you. So our goals today are to enhance understanding of equity issues in mental health, but as I already said, we also want to hear your ideas about what action is needed at the individual, organizational, and policy planning levels to advance equity in Ontario. So you'll have a lot of opportunities during today's session to tell us what you're already doing in your organizations on these issues. So at this time, we'd like to learn even a little bit more about all of you. So first of all, we'd like to know how many of you have participated in one or more of our previous webinars as part of this series. I'm going to pull up a poll in a second, and then we're also going to pull up a poll after that. That's great. It looks like about 70% of you have participated in one or more of our previous sessions, and so welcome to those of you that are joining us for the first time. Then we'd also love to know how many of you encounter equity issues in your day-to-day work. And of course, 100% of you have encountered equity issues. So today's session, just as some of our previous sessions, is based on a framework that was developed here at CMHA Ontario called Advancing Equity in Ontario. And I'd just like to start our session by telling you a little bit about this framework and about why we developed it. So this document, which you can find at the URL that I've posted there, is just a very, very simple framework. It's very visual in nature, and we developed it in order to build a common language and understanding about equity issues in mental health. So those of you that are working within the mental health system probably have heard more conversations and more interest in health equity and equity at different levels. The province has been talking about it, your LHINs have been talking about it, and I'm sure some of your organizations have been talking about it. So at CMHA Ontario, when we heard these conversations, we were very interested to explore what equity means when it comes to mental health. Because as you're going to hear a bit later, our starting point was really this acknowledgement that all of the work that we do is really about equity. So this particular framework is a foundation for action, and what we'd like to do today is hear about some of your thoughts on how we can actually take concrete action. I think what's most exciting to us about the framework, though, is that often when we put out policy documents, we have the interest of other stakeholders, of government, and this happened in this case as well. We had a lot of positive feedback from different stakeholders in the health system, but we also had really positive feedback from people in other parts of the community and social services sector as well as settlement sector. But we also heard a lot from people, so just everyday people, the public. And we promoted this resource through social media, and we were really happy to see that people felt that the ideas really resonated with their lived experience. So that's something that was really exciting for us and that we're really happy about, and that really validated, I think, the value of this work and why it was important to share. So our framework starts with a broad definition of mental health, and the definition that we use comes from the Public Health Agency of Canada. The definition we use states that mental health is the capacity of each and all of us to feel, think, and act in ways that enhance our ability to enjoy life and deal with the challenges we face. It's a positive sense of emotional and spiritual well-being that respects the importance of culture, equity, social justice, interconnections, and personal dignity. And it's important to us to start with this particular definition of mental health because it goes much more beyond illness. And the model that we like to use to think about mental health at CMHA Ontario is this two-continuum model. So this two-continuum model really reflects that shares that there are multiple dimensions of mental health that are critical for any work that we're doing in this area. So you'll see that there's two intersecting lines in this diagram. That blue line reflects the continuum of symptoms of a mental health condition to no symptoms of a mental health condition. And we all sit somewhere on that line at some point in our lives. At every point in our lives, in every moment of every day, we're somewhere along that line. And where we are on that line can change depending on what's happening in our life and other factors that I'm going to share in a moment. There's a second line, though, that's also part of this diagram, which is that green line. And that reflects the continuum of poor to positive mental health. And again, at every moment of every day, we also sit somewhere along that line. And most importantly, our mental health can be understood as a function of both of these dimensions. So what this two-continuum model really tells us is that it's possible to have a mental health condition and experience positive mental health. So you can be living with a condition like schizophrenia or depression and actually be doing quite well. It's also possible, however, to experience poor mental health without a mental health condition. And I think that's something that we have all experienced. We all have moments in our lives based on what's happening in our lives where we're not doing as well. And so it's important to bear both of these things in mind. So what are some of the factors that impact on where we sit in this particular model? The social determinants of health are particularly important. These are some examples of the social determinants of health, and I'm sure Most of you are familiar with this concept, but these are essentially the socioeconomic factors that influence on health and mental health. And these factors have actually been shown to be as or more important than lifestyle and sometimes even biology in determining our health and mental health outcomes. So some of the examples you see in this diagram are employment and working conditions, sexual orientation, gender and gender identity, race, social exclusion, our early life experiences, and Aboriginal status. Now, when it comes to mental health, there's 3 factors that researchers have identified as particularly important. I'm sorry, I'm just noticing that some of you are saying that the sound is too quiet. Please make sure that your speakers are up all the way, and I'm going to try to speak up as well directly into our microphone. So in terms of mental health, the 3 social determinants that have been identified as particularly significant are discrimination and violence, experiences of social exclusion, and experiences of poverty or access to economic resources. And I think all 3 of these factors point to the importance as well of acknowledging trauma when we're doing work related to mental health. So this illustration helps us to understand the impact of the social determinants of health on our journeys towards positive health outcomes and mental health outcomes. So we see at the top an individual who has access to education, income, and employment is just running towards health status, towards their health. They're on their journey towards health, and they're just running towards that finish line. On the bottom part of the screen, we see someone who's experiencing social, economic, or political marginalization related to issues related to the social determinants of health. And they have some added challenges that they're bringing with them as they journey towards their health outcomes. So this brings us to the concept of equity, which is very connected to this idea of the social determinants of health. At its most basic, equity is simply a way to understand and respond to marginalization. And I'm sure this is something that all of you are encountering in your day-to-day work. Inequities are rooted in the uneven distribution of power and resources in society, and this can really be understood as uneven distribution of the social determinants of health. Equity is also in understanding that different populations need different actions sometimes in order to achieve similar outcomes. And this is probably also something that you see on a day-to-day basis in your work. So experiences of inequities can intersect. And what this means is that many people that we encounter in our work and in our lives, and even ourselves, can experience multiple forms of inequity or marginalization at the same time. So I'd love to ask you guys some questions now that really get to the heart of what intersectionality is. In your opinion, what factors intersect to shape mental health and daily life for? And I have a couple of examples there. Let's start with a 15-year-old who's just arrived in Ottawa as a refugee. And feel free to type into the chat box. So Mariam suggests that a sense of isolation, absolutely. Victoria points to language barriers. Immigration status is certainly a significant impact on significant determinant of social determinant of health. Age barriers, absolutely, in education. Loss of family support. So I'd just like to remind everyone at this time that if you're having any troubles hearing us, please feel free to dial into our teleconferencing line. And Angela, who's doing our, who's managing our webinar, has just posted the number there. So please feel free to dial in via the teleconference if you're having trouble hearing us. So let's skip to the bottom example. What about for a South Asian woman who's living with bipolar disorder in Waterloo? What are some of the factors that could intersect to impact on her mental health and her daily life? So someone suggested financial insecurity. Absolutely. There's a lot that we know from the way that these individuals are described here, but there's a lot that we don't know. We don't know about her income situation. We don't know about this woman's employment situation. So Victoria suggests cultural stigma, maybe if her culture does not support accessing mental health supports. And as we've known from our previous sessions in this series, Many individuals experience multiple barriers when accessing mental health support. So that's a very important point. Scott says language barriers. Mental health, race, and ethnicity. Great suggestions. So you've already started to identify some of the challenging relationships between equity issues and mental health. And a big part of our framework was really to capture in a simple way what some of those dimensions of the relationship are. So there's 3 dimensions that we identified. The first is that equity impacts on mental health. And this concept is really that due to the social determinants of health, populations that experience inequities face greater risk of mental health and some mental health conditions. We're just going to ask all of you to mute the line. If you are dialed into our teleconference line, please use the mute function on your phone. That'll help with the sound quality for everyone. Thanks so much. Due to the social determinants of health, populations that experience inequities face a greater risk for mental health and also some mental health conditions. So we have some examples here on this slide that really point to this. So for example, and this is really, I think, a heartbreaking situation, that LGBT people face higher rates of depression and anxiety, and LGBT youth in particular face approximately 14 times the risk for suicide than their heterosexual peers. We know that Ontario women are twice as likely to report depression than men. And looking at the gray box there on the slide, lowest income Canadians are 3 to 4 times more likely to say their mental health is fair to poor than the highest income Canadians. So the second dimension of the relationship that we believe is important is that mental health impacts on equity. So people living with mental health conditions face discrimination, stigma, and social exclusion that impacts on almost every part of their lives. So for example, the Ontario Human Rights Commission documented in a couple of years ago, extensive discrimination that people face when accessing housing, employment, and services. And unfortunately, we know that these are critical social determinants for mental health. And I think a stat that really brings this point home is that years ago, the Salvation Army conducted a survey and found that
participant lines muted.
Almost 1/4 of Canadians surveyed are actually afraid of people with mental health conditions. And the final dimension of the relationship that we focus on in the framework is that intersectionality matters. And so we've already talked about why intersectionality is so important. But people who experience intersecting mental health issues and marginalization face added inequities. So as we've discussed in this webinar series, immigrant, refugee, and ethno-racial groups face language gaps, discrimination, ineffective or inappropriate service models, and overlapping social determinants of mental health when accessing services. And some of you that are coming to us from the north part of the province know that Northern Ontarians report higher rates of depression, higher use of medication, and higher hospitalization rates, but yet have access to a less comprehensive, available, and accessible basket of services, also an equity issue. So who's impacted by these issues? Well, we know that people living with mental health issues are impacted by equity issues, but we also know that any marginalized population is going to experience equity and mental health issues. The reality, though, is that many individuals fall into this overlapping category in the middle. So many individuals experience both mental health issues and other inequities at the same time. So in our work, it's important that we pay attention to all of these population clusters. So what can we do? And that's really where this webinar is going to focus most of its time. So at the organizational planning and policy levels, there's 3 sort of main areas of recommendations that we have. One is to make equity a priority. And there's 2 ways that you can do this: to consider equity when doing mental health policy and planning at all of the 3 levels that I mentioned there, but also to expand the evidence base for equity issues in mental health. The second is to make the social determinants of health a priority, both in your relationships with your clients, in the work of your organization, but also in planning and policy. And finally, to make people with lived experience and other marginalized populations a priority as well. And this can involve fostering meaningful participation of people with lived experience and marginalized populations in your work, and also challenging the discrimination, stigma, and exclusion that people with lived experience face in many parts of their lives. So at this point, point, I'd love to engage all of you and our two guest speakers into a broader conversation about what we can do to build a framework for action. So the framework that CMHA Ontario has already developed really set the foundation for these key concepts, but now we'd like to move towards an action framework. So at this point, I'd like to welcome Uppala and Deqa back into the conversation. And to get started, I wondered if each of you could tell us a little bit more about what you do in your current role. I can start with you, Uppala.
Sure. Can everyone hear me okay? Why don't I start with just a little bit about Canadian Mental Health Association. We are the largest community-based mental health and addiction provider in the country. We exist in about 120 communities coast to coast. And at the local level, at our branch level, this is where we provide direct services to clients. So access to clinical support, case management, housing, court support. Really our branches do all the work in providing access to individuals and communities in terms of accessing social determinants of health. And at the provincial level at CMHA Ontario Division, where Sheela and I both work, we help to advance health and public policy, and we support system change to better address mental health and addiction.
How about you, Deqa? Tell me a little bit more about what Fred Victor does and what you do at Fred Victor.
I'm a mental health promoter, and I work at a program called Mental Health Promotions Program, which we focus on, basically we do a lot of training, working with, in partnership with people with lived experience in developing sort of a startup programs. We run wellness recovery program groups. We work in community development, organizational development, and program development areas. We provide education and training, information development and dissemination around mental health and addiction. But in terms of, so within that, I work at Fred Victor. So in the past 120 years that Fred Victor has been in existence, organization has focused on working with people who are facing marginalization and living in poverty. We've done a lot of things around focusing on social determinants of health, meeting people's basic needs, food, shelter, employment, education, access to supports and access to information, and we do this through advocacy as well as providing housing, both in the form of transitional housing, shelter, as well as permanent affordable housing.
So I wonder if you could both tell us a little bit about how equity issues impact on your work. And I also wanted to ask our participants to think a little bit about how equity issues impact on all of your work. So we're going to pull up a chat pod, and I'd like you to start thinking a little bit about this and sharing some thoughts with us as well as Deqa and Farah are sharing their stories. So Deqa, I wonder if maybe we could start with you. How do equity issues impact on you?
Well, equity issues, when you're working with people who are who live with mental health challenges, and chances are there are other additional barriers and intersectionalities around issues around race, sexual orientation, gender, income, social location, in terms of geographical locations, and various other challenges, language, and all of those other areas. So some of the things, and in terms of when you work, like from an experience of working with people, you know that those issues are important and they affect people's lives, and considering health equity is an important aspect. If you look at in terms of studies, the studies show that immigrant and refugees and people who are facing marginalization and social exclusion, there's a correlation between their status in terms of as a minority, social exclusion, and their health status, and the way the system responds to their health, access to health, as well as utilization of health services. there is many studies that show, in terms of the one that Toronto Central Lynn has done, is showing that people who are in low income utilize emergency departments more than people with higher income. There's also, so there are many correlations between income, social status, social exclusion, and access to health, as well as people's health, because those being marginalized, facing racism, facing multiple barriers, low income, affects both mental and physical health. So it's, as an organization, any that work with individuals with who, it's important to consider health equity and to have an health equity class.
How about you, Sheela? So you're working more at the policy and planning levels. How do equity issues impact on your work?
I would say that at CMHA Ontario, everything we do is about equity, and we're working towards ensuring equity for all Ontarians with mental health issues. One of our main functions is to influence policy and change at a provincial level. So in order to do that, we look at legislation, policy, and any directives proposed by government, and we filter it through a mental health and addictions lens to see what are the positive impacts on people with mental health and addictions issues, and what are some of the unintended negative impacts. When there are unintended negative impacts, we work together with government to help mitigate some of these negative impacts. So at any given time, we're working with up to 14 different provincial ministries, as well as all the LHINs. And there are 5 main areas that we focus on at CMHA Ontario, and we have a lead in each of these areas. So one of the areas is the provincial health system, so looking at any directions from the Ministry of Health or public health authorities or the LHINs themselves. We have a lead on social determinants of health, so looking at specifically issues related to housing, income, and employment, and education, and looking at the social support structure like the Ontario Disability Support Program or Ontario Works. We have a lead that specifically focuses on the criminal justice system and the impacts of that on people with mental health and addictions issues. And then we have Sheela, who does all of our equity and social inclusion work, and she's the lead for all of that.
So it's interesting to see some of the ways that equity issues impact on our participants' work. So Miriam, I think is a service provider. Maybe Miriam, you could tell us what you do. She says that it constitutes a barrier towards building a functioning relationship with clients, since at times they confuse her role as one aimed at providing financial help. So it sounds like access to income support is a significant issue in some of your clients' lives. Victoria with Lambton Public Health says that her role is called a social determinants of health nurse, so it's part of her everyday work. Every committee she sits on and helping other departments with program planning, any learning opportunities are all equity focused. That's great. So Miriam's work is on intensive case management with refugee populations. So I'd just like to encourage all of you, if you have any other ideas to share about how equity issues impact your work, feel free to tell us a bit more. And while you're typing, I'm just going to ask, okay, so Michelle says barriers to access for students and their families. Michelle, are you a teacher? Maybe you could tell us a little bit about what you do. We know that we have people participating in these sessions from all different sectors, including education and child protection. So Michelle is a mental health lead, perhaps within a school. So Jasmine says that her clients often need help with the social determinants of health before they can even address mental health challenges. So that sounds similar to what Miriam is saying. So thanks so much, everyone, and feel free to continue typing as we continue chatting. So the next thing I'd like to ask Deqa and Uppala is why you think it's important to address equity. Since you're both working at different levels, Deqa, you're working at the level of service delivery, and Uppala, you're working at the level of policy and planning. Maybe we can start with you, Uppala. Why it's important to address inequities when it comes to mental health policy and planning?
I think there's so many pieces that we can focus on. I think there's so many opportunities right now from mental health and addictions, and there's so many challenges as well. So maybe I'll focus on kind of 3 main areas. I'll start with the challenges. and then I'll talk about the opportunities because it's really an important issue that impacts both private sector and the public sector. So right now, for us, it's really important that we look at, first and foremost, mental health and addictions as an equity issue in itself. So we often say that mental health is health's poor cousin, and that's because resources are not equitably distributed to mental health and addictions the way they are to other parts of the health system. So in Canada, only 7% of public spending goes to mental health. And this is far below what other countries like the UK and New Zealand spend. They spend up to about 10 to 11%. And so first and foremost, we need to ensure that the national mental health investment is increased from the current 7% to at least 9%. And both the Mental Health Commission of Canada and the CMHAs around the country are advocating for this increase in funding. So first and foremost, we need to kind of ensure that mental health is seen equitably like all other parts of the health system. Another challenge I see right now in terms of mental health and addictions is ensuring that there is health in all policies. In this case, ensuring that there is mental health in all policies. And what I mean by this is that we need to ensure that when government proposes changes to economic or social or justice policies, that they don't have an unintended negative impact on health and mental health. So for example, we have a new policy in Ontario to expand the sale of wine and beer in grocery stores. This is great for the economy, it's great for businesses, but what are the unintended negative impacts on our mental health and well-being? So we need to ensure that there are strategies in place at a policy and planning level to help mitigate any of these unintended negative impacts. So now with this new wine and beer policy in the province, this creates an opportunity for government to develop an alcohol strategy for the province. And there are many partners like CMHA, the Addictions and Mental Health Ontario, and the Centre for Addiction and Mental Health that have come together and offered our support to government on this front. So there's lots of opportunities. And in terms of the third major challenge I see for the system, there is a need for an increased evidence base on equity. Policy decisions at a provincial level and at a LHIN level are made based on best available evidence. But unfortunately, we lack an evidence base around equity issues, especially in mental health and addictions. We need an evidence base that has valid data and effective performance measures to advance equity issues. And we need to have a clear picture of what we look like now so that we can lay the foundation for how to improve for the future. This means things like collecting sociodemographic data to better understand our service users now so that we can begin to measure how we're meeting their needs and improving our services in the future.
Very interesting. It's Victoria from Lenten Public Health also says it's important to address inequity because there's still confusion or just not knowing the difference between inequality and equity. An important point. And Scott, I think this is a response to our previous question about how equity issues impact on your work. So if he's a teacher working in a care, custody, and treatment facility in Ontario. Many of his students have different backgrounds and different experiences, and they're when students talk to one another, they become aware that some students have more than others. It could be money, family members who are present in their lives, or other things. And it sounds that those factors are impacting on their educational success. Maybe, Deqa, you could tell us a little bit about
why is equity important to address? Why is it important to address inequity? Well, I think we're all in agreement that social determinants of health are important. And so if you're considering access to information, living in a good environment, safety, free from discrimination, early childhood and any support that you get, whether it's a community support or family support, all of those things affect individual health, affect your health, and it affects you throughout your life. And so if we're all in agreement in that, it's important then to address inequity. So it's like when clients come to us often, they've faced a number of inequities, a number of barriers that affect their lives, that led them to where you're meeting them at. And then those barriers maybe get more complex as when you have mental health, physical health, and all of the other intersectionality, when you race, ethnicity, gender, disability, and language, and all of that. So as an organization or as a service provider, it's important to consider those barriers and those pieces of the individual's life that impact on their health, but those are also impacting on their access to services and utilization of services. So if, as an organization, if we're serving a population, one size fits all is not workable, because you might be addressing one aspect of the individual need and in the individual's health, but you're not addressing all of the other aspects that impact on their health and might lead to recovery or impede recovery. So like in a very basic way, that's why it's important to have access. So for example, if you're an organization that provides therapeutic services or services to people with mental health issues, and most of your services, even though you have maybe 30% of your clients are people who speak different languages, but most of your services are delivered in English. Most of your services are delivered, you don't consider the literacy level, you don't consider. So that means there's a huge population, part of the client that you serve, that are maybe getting not the full service that you offer, because there are other barriers. There are cultural barriers, language barriers. Some of their other issues are not addressed. For example, immigration and various aspects. So that's why it's important when you have a health equity plan, you utilize the data that you have. Then you look at the client's need, and you consider and you plan for the need of your actual clients, not what you think best serves the clients. And then that also impacts the partnerships that you build, the system advocacy, because some of the things that we can provide depends on the system. So for example, organizations might not have the money to provide interpretation services, or might not. So, and then it would impact on your hiring practices. So if you have 20% of your clients who speak various languages, are you providing services in that language? Are you hiring? What kind of a support are you providing to the staff and to the clients in that particular designated area? So I think it's important to consider that in order to meet the needs of the clients.
So I think one of the things that I really heard you saying is that these issues, equity issues, significantly impact on client outcomes.
Yes.
So it's absolutely important. And I hear that in what Maggie is writing there. She says that she provides employment services. Her organization, I think, provides employment services, and equity is important. But they have clients that feel they're not able to access employment because of mental health issues. It may be that they have PTSD, anxiety, bipolar, or other mental health conditions, which they feel are major barriers to their employment. So actually, Maggie is not working in the mental health system, but in the employment sort of sector, and is finding that mental health issues intersect in that way. But we heard a couple of participants type earlier that they felt that before they could even get to providing mental health services, they have to address income issues or other issues. I just wanted to also pick up on what Nuria posted. She says that her clients, many of them are newcomers, often ask how to deal with the inequity of not having Canadian experience, and that this impacts on their mental health as they become depressed due to rejections. Is this something that you found as well, Becca?
Yep.
I see Scott is typing something, so I'm going to give him a second. We're not going to change the page while he's still typing, but I wonder if we could move into the sort of solution side of the conversation. And Becca, you were already starting to do that a little bit when you were talking about health equity plans. But I wondered if we could talk about what can be done in service delivery And if we could also think it through along those three major areas of recommendation that we identified in our framework document. So the first is to make equity a priority. The second is to make people with lived experience and marginalized populations a priority, and finally to make social determinants of health a priority. And before we move on, I want to acknowledge Scott's comment that he says that he likes that we touch on the major barrier of literacy levels. I think you touched on that, Deqa, because many of his students read well below their grade level, and that causes the number of inequities. So in terms of what can be done in service delivery, I wonder if we could look at it again, as I said, along the three areas of recommendation that we have identified in our framework document. So first, Deqa, could you tell us a little bit about how you would just make equity a priority?
So I think it all starts with, because I think every organization, people who work in the social service sector, education, any of that, people are there, they're committed to equity and they're committed to these issues. But what tends to happen often is that you might have it at the service delivery level, but you might not have it at the organizational planning level. So what's important is that you have a health equity plan at the organization level, and that plan addresses all aspects of the equity level. So it addresses at the service delivery level what that looks like, at the planning, at the organization and program level, what would be needed, and at the organization level. So you're looking at it from the governance, management, service delivery, and the client level. Otherwise, it just becomes informally delivered services that might transfer to different parts, but it's not across the organization, and you cannot also evaluate whether the service is actually meeting the health needs of the client, if it's impacting on the health outcome of the client. So that's the first important part is that. And so in order for you to have a health equity plan, what's important is collecting socio-demographic data. And that socio-demographic data gives you an important window to your clients and what are the met needs, what are the unmet needs, and the pressure areas, and what are some of the things that are that as an organization that you don't have some of the resources. So where you can provide different partnerships. So for example, somebody mentioned employment. One of the issues that come up is some aspects of the social determinants of health. While you're addressing issue of employment, you don't have mental health comes or health. So what partnerships are you developing once you realize what are some of those needs and some of those issues? Also having in that data indicators to assess program, whether the program is meeting the needs or not. Developing also population-focused services. So those population-focused services would help address certain unique needs that population has. So for example, if you're working with women, looking at issues around, if you come up trauma, for example, there's like sexual trauma, there's immigration and trauma, then you develop services that's tailored to that particular population, and you meet those needs. The other part is fully addressing social determinants of health.
I just want to, before we move on to the social determinants of health, I just want to take on Khadijah's comment. She says, I don't think we're creating surveys well or interpreting data well, and this is why marginalized communities generally don't access services. I wonder if you could talk about at the client level, you talked about using OCAN.
Yes.
Is there a way that organizations within the community mental health sector could start to collect some of this data a little bit more effectively, perhaps at the client level with OCAN, for example?
Well, I think OCAN is actually a good tool, but it's not across the sector, and it's not across all organizations. So OCAN is Ontario Common Assessment of Needs, and it has about 21 domains, and it sort of fully addresses that. There are some demographic questions. But to this day, I'm not aware of organizations that are actually using that data and those demographic that led to a change. I might be wrong, but I haven't heard in the sector. So I think collecting data, not just collecting it, but using it at the organizational level and changing your service, but also at the system level. So at the system level, if there are consistently certain areas that there are unmet need or more needs. So for example, housing is a huge area, and income is a huge area. What are at the planning level, and maybe Uppala can talk about that, some of those issues. So housing stock is like there isn't much housing. So those are one consistently area that comes up often as a barrier, as a need. So at the system level, how is this data used? But I also think that organizations' health equity plans should be something that is tied into funding and funding allocation, and that way organizations will take it seriously, and it's not just a burden on them of collecting these data.
So I wonder if we could move on to the social determinants of health. And you've talked a lot about the organizational level and things that the organizations can do. I know a lot of our participants are working directly with clients or service providers themselves. I wonder what's one way or what's a few ways that we can make the social determinants of health a priority in client interaction? That's a question for you.
Oh, is it? Sorry. In the client relation. So in the client relation, I think that aspect of, first of all, working in partnership with the client, finding out what their needs are, collecting that information, and looking at in a systemic review of what are their needs. So one of the things that are important is having people with lived experience. So for example, developing, somebody talked about survey and needs assessment, and looking at that is delivering services from a perspective of people with lived experience. Also providing, looking at income and providing, for example, tokens when they're attending your services. Looking around issues of geographical locations of your service. Looking around issues of, as I said, population-focused mental health or health services or services in general. So are you providing services to looking at a specific need of your clients? Hiring people who relate to the client and looking at language specific and providing and removing any of the barriers within your organization.
I think when we met to plan this session,
I kind of lost the question.
I know when we were planning the session, we also just talked about asking questions about the social determinants of health when you're providing.
And asking questions about the discrimination and issues that people face and how those social stressors and those pieces affect their access to services. And making prioritizing the individual need in terms of not only what we provide and the basket of services that we have, but what the individual actually needs.
So I'd really like to encourage all of the participants to share their thoughts as well about what they're doing in their organizations. What are all of you doing right now, or what would you like to be doing in your organizations to make equity a priority, to make the social determinants of health a priority, and to also make people with lived experience of mental health issues and other marginalized populations a priority at the level of service delivery. So as we move into making people with lived experience and other marginalized populations a priority, we had a suggestion from Jasmine that consulting with people with lived experience when creating service delivery plans and creating programs is key to ensure that their voices are heard and their needs are met.
Yes, I agree.
What are some other ways that you can make people with lived experience a priority?
Well, I actually going to plug in CMHA Toronto's service. There is some sort of a, like, I've heard recently that they're doing an assessment of all of their services where they've hired people with lived experience to evaluate the services, whether the service meets the need. So I think that's a really important aspect of looking at your service. So one of the things that we do, for example, is we have some program called Wellness Recovery Plan. That program is for people with lived experience, and it's run by people with lived experience. And what's important is looking at ways of providing support to people with lived experience when they're delivering services, and that ensuring that those services are not marginalized within your organization, but looking at ways that throughout the organization it's supported and incorporated. So it's important for people with lived experience to be on your board. It's important that they have a say at the service planning level. It's important that they have a say when, or their input is incorporated into the service into the service delivery level, and it's important that they have that input is meaningful, and it's not just a survey or you do a focus group, but it's actually incorporated into the level of the service delivery.
So Khadija has a comment, I guess. So she wonders if it's too simple to say to ask people about the challenges that they're facing, because if you ask somebody with a mental illness if they have any illness or social problems, they generally say they're fine because of either internal stigma, denial, or lack of awareness. She says this is a huge issue that's, I think, impacting on her service delivery. What are your thoughts on that?
Well, I think internalized oppression or internalized stigma is a huge piece. And when somebody comes to you, they don't only have mental health challenges, they have other issues. So I think the way I generally worked with individuals who had stigma is work with them on their needs, on what they have right now. So a priority might be housing, or might be immigration, or might be, it's a self-determination. But at the same time, I think when you're developing the therapeutic relationship, I think it's important to ask the individual around those social issues and challenging the stigma and facing it and supporting them around addressing it. So one of the things that the OCAM, for example, has those questions where you're asking about the person's, you don't ask about, so for example, we don't require people to have a diagnosis, but we ask them about their experience and how that experience impacts on their lives. So you ask them about the symptoms without asking for symptoms, but asking about their experience. So how do you experience that? What do you call that? What is it? How is it impacting on your life? But to me, I think it's really important that the same way that I would address issues around internalized racism and internalized homophobia or internalized oppression, that internalized stigma is a huge part that prevents people from seeking services. It prevents it causes them a lot of stressors. So it's a way to support them and to work with them around those internalized issues.
I think something really interesting you said is rather than focus on symptoms or diagnosis and use the language of, say, mental illness, you talk about experience. That's a very valuable takeaway. Yeah. Maybe we can move to the level of policy and planning. Well, I wondered if you could also talk about, along these three sort of action areas, what we can do when it comes to policy and planning, starting with how we can make equity a priority.
Yeah, for sure. I want to start with something Deqa said about the importance of having health equity plans in organizations. I absolutely support this, and I think it's very key. And I really agree with tying that to funding and accountability. For many years, I sat on a board of a community health center in Toronto. And in order to receive funding from the City of Toronto, we actually had to adopt a health equity vision. And it was an agenda item at the board level, and we all agreed to it, and it was the condition of our funding. And I thought that was really excellent because it encourages to think about equity issues, not at a service delivery level, not only at a service delivery level, but at the level of governance as well, which is really where a lot of the visioning and the planning for an organization happens. So we need to ensure that not just service providers, but our management teams and our governance and board levels are engaged in this idea of equity. So I think it's very important for health equity plans to be included as part of the mandatory requirements for agencies in terms of their reporting. Also in terms of reporting and planning at a policy level, I think we do need to start with the data collection piece because it really impacts on, it kind of has a cascading effect on a lot of issues. So when we have valid data and reporting, then we can measure our performance. And once we're able to measure our performance, then we can improve the quality of our performance. So all of that is tied back to this idea of data. So data collection, especially in terms of sociodemographic data, is very important and very key. Because if we don't have a picture of what we look like today, we can't possibly improve for the future. And in terms of the data collection piece, I think we need to explore what data is available now and what is needed for the future. I think we need to look at what's working well in some areas and see how we can scale that up. And I know that a lot of local health integration network communities, there's a lot of great data collection that's happening on the equity front, and there's equity indicators being built. And so we need to see what's working well, what are some promising practices that we might be able to bring provincially and even nationally. We don't have to wait for the perfect tool or the perfect system. We can start, we need to start somewhere now, start collecting at a very small level. Maybe it's starting with asking questions around housing and employment and race and sexual orientation. And we can do this in kind of a staged approach. If you're collecting this information at an organizational level, you can embed that into your improvement processes. And then we can take it a step higher to a regional level, see how regionally what does our client base look like, and then eventually up to a provincial level.
What about in terms of integrating the social determinants of health and making that a priority in terms of policy and planning? So one thing we know about mental health is that it is extremely cross-sectoral, that it involves all different dimensions of social policy because of the importance of the social determinants of health for mental health and addiction. So how do we make the social determinants of health a priority when it comes to policy making and planning?
A couple of things. One I touched on before is really that idea of having health in all policies, or mental health in all policies. So we need to ensure that policy development at a regional level and at a provincial level doesn't have any unintended negative impacts on our health and mental health and well-being. And so we do need to look at everything from a mental health lens and analyze, does this economic policy hinder our client base, or does it help our client base? And does the social policy hinder or help our clients? Same thing with justice policy. There's so much happening right now in the area of the criminal justice system, and a lot of those directives have an impact on our client population. So we really do need to look at and ensure that when policy directives are put forward, that they don't have an unintended negative impact on people with mental health and addictions issues. Another key piece, I think, at a policy and planning level, and this is, at a regional level, at a provincial level, and at a national level, is we need to ensure that we are champions for the community-based mental health and addiction sector in general. And I spoke about this earlier, about ensuring increased investments for mental health and addiction, especially in the community. And that's because at a community level, this is where we are providing the social determinant services. So we're ensuring that community-based providers are assisting clients with housing, with case management, court support, employment support. That's a very big one, employment support. So we need to ensure that there's adequate resources and supports going to the community-based sector. It's really important to remember that people with mental health and addictions issues don't just need clinical interventions that are available at a hospital level. Yes, those interventions are very important, but it's also important that we support their recovery in the community and ensure access to the social determinants of health. So we need to ensure that there is an equitable distribution of resources available to community-based sector and agencies in the community.
We have quite a few comments and suggestions, and I'd really encourage all of our participants to share even more thoughts about what you think needs to happen at the policy and planning level in these areas. I just want to pick up, Uppala, you talked about the importance of collecting socio-demographic data. Khadija points to the importance of when those data questions are being developed, that it's important that the language actually connects with the individuals that will be responding to the data, so to the clients. This is something that I think, Deqa, you also picked up on when you talked about some of the tools at the client level. Uppala, I wondered if you could talk a little bit about that, about how important it is to ensure that data collection actually resonates with the population.
Yeah, and I know that there was a comment earlier about, if we ask a client a straight-up question, they might not answer it because of stigma and not wanting to share that experience. There's lots of creative ways to ask the questions, right? For example, if you want to understand the level of income someone has or whether they have stable housing, you can always ask a question like, where do you eat, right? That would give you an idea of the individual, whether it's, are they accessing food at a community space, a shared community space, or do they have access to food at home? So it's about being creative on that front. And in terms of a provincial level, the Ontario Common Assessment of Need is really fantastic because it does capture a lot of that information. And the challenge with OCAN is that it's not a mandatory tool, so not 100% of our community-based mental health and addiction sector is using this tool. So at a provincial level, it becomes tricky because we can't see an accurate picture because only some organizations are using it and others are not. So we need to ensure that the assessment tools that we are using are becoming a little bit more standardized so that we can have a clear picture at a provincial level. Because in terms of policy and planning, as I said before, policymakers, especially in government, are relying on an evidence base. So if we can't find and develop the numbers for them, they don't have the accurate information in front of them to make the decisions. So we need to figure out how do we get the right information, the right quantitative information into the hands of policymakers.
And go ahead.
Sorry, can I just address 2 points that I see here? One is issues around the data question. I think it's important, it's not only about the client or the agency or how it's written. I think it's about the service provider and how that question is delivered and how you, knowing your clients, what you're asking. But also it's issues around the training that people have and making sure that it's not the service provider worldview as opposed to the client worldview, and how you're not anticipating certain population clients have a stigma around mental health. So therefore, I'm not going to ask that question. So I think that's very important. The other thing that I see is around issues around data collection being time-consuming for the client as well as the service provider. And I think that's where it's important. That wouldn't be the case if those data collections, the data that the clients, that we're collecting from the clients are used for service planning. They're used for system planning. So that's where the agency having a health equity plan comes in, because if you'll use that data for service allocation, for resource allocation, for planning the service for the client to meet the needs. So, and partnership development. So if you have a particular area where consistently there is unmet need for the client, so the agency is not meeting the clients, then that's when you sit in and plan. And so one of it could be seeking additional funding or allocating additional funding. It could be also be around the partnership development. So if you're a mental health agency and you have a group of consistently issue around immigration and citizenship and issues are coming up in your data and your clients it's an unmet need, then you develop a partnership with a settlement agency and you sort of, if there's housing or if there's employment, so I think the data becomes a waste of time because it's not used for service planning and for system level planning.
I think that's a good point around partnerships, and I want to go to what Kendra mentioned, which is the importance of involving in policy and planning local academics and research institutions in order to develop and implement data collection and other analytic activities. Uppala, I wondered if you could touch on, before we go to the last sort of area of action, I wondered if you could touch on the importance of collaborative policy and planning work at this level in order to do equity.
Yeah, I definitely agree. I think that is a really great comment made by Kendra. I think it's really overwhelming if we think about this as a structural issue because there's so many intersecting factors. So I think we need to kind of break it down into a manageable size and do it in partnership, right? And we don't have to start on a large scale. We can start small. But the danger is that if we don't collect the information, we actually don't know what gaps we're missing, right? So I know, let's look at it at a national level. For the last 10 years, the census long form has not been used, right? So now this year, we're starting the collection of that data again. And the danger of not having that information is because we don't actually know what we're missing out on. And that's what's so important to measure and collect, because we need to have a clear picture of what we're doing now. And without collecting that information, we just don't have any sense of what we're doing right and what we need to improve on. So in order to do quality improvement and performance measurement effectively, you need access to the data. And I'm a big fan of partnerships with academics and researchers in the community as well as in academic institutions. There's so many creative ways for us to get our hands on data and to do some of that high-level analysis. At CMHA Ontario, we look at something called the Health Data Branch Portal, which is really the funding, how it lists annually all the funding that goes to different streams and funded through the different lens in community-based mental health and addiction. So we're able to look at kind of a provincial level, how much was spent this year on health promotion, how much was spent on housing support, how much was spent on employment support. And even that level of data collection and reporting is important because it allows us to see the trends and the priorities and the investments that are going into community-based mental health and addiction.
So we've talked about making equity a priority for things like data collection. We've talked about ensuring that the social determinants of health are a priority. What about ensuring that people with lived experience and other marginalized populations are a priority when it comes to policy making and planning? And I think this is an area of particular challenge because I think there's many that would feel that at this level of work, it can be very difficult for marginalized populations to have a voice and to be engaged.
Yeah, I'm just reading some of the comments here by Victoria as well. What she says about sometimes we use jargon or high-level and direct language, which can be very off-putting for people with lived experience. I definitely agree. I think in order to effectively engage people with lived experience at the planning and policy level, it can't be a tokenistic exercise. It has to be meaningful engagement. And so you need to engage people from the very beginning. And we need to find effective roles in policy and planning. So this might be, presence of a person with lived experience or an organization that represents people with lived experience at a LIN level planning table or at a ministry level planning table. And it's really important that people with lived experience are actively engaged in the policy-making process. I know that government often does this in terms of whenever they release a discussion paper, they open it to the public. And so those kind of create opportunities for us working in the community-based mental health and addiction sector. We could hold our own focus groups to respond to directives of government, right? We could enable some of that systems change to support government in that way. I also think it's important that we provide support to consumer survivor organizations and help enable those organizations to come to planning level tables and policy level tables. Because at an organizational level, at that level, they may be able to tell us more about the system as a whole. When we have individuals with people with experience at planning tables, they're really only able to talk about their own experience and their own journey, which is very unique to every single person. But if we have an organization, then they're more able to talk about a more high-level systems approach that many people might be going through. And the third thing, I think, in terms of engaging people with lived experience, we need to think about their perspective when we're developing performance measurement indicators and performance measurement processes. We need to ask them, what do you want to know about the performance of our system, right? Because what they want to know might be very different than what we want to know as service providers, right? So they might not care at all where the funding comes from. They just want to know that a certain service is funded. But as a service provider, we might care which ministry it comes from, et cetera, et cetera. But at a client level, their needs and what they want to know about the system might be very different than what we want to know as service providers.
I think, can I just add one thing around the service provider, consumer survivor involvement? I think people with lived experience, generally it's important to involve them at all levels, from the policy planning to organization top. But I think what needs to happen is providing people with support, paying, for example, paying them for honorarium when they come to these meetings, because us service providers go to these meetings and we're paid, our salaries are paid. The people with lived experience are not getting paid with salary level, but also if you're involving them at a committee, high-level committee, I think it's important to provide some sort of a training and support before. So somebody who hasn't been in a committee before, somebody who hasn't been, they might not be able, and it becomes tokenism. The person just sits there and maybe says a few things. But if you provide training, and maybe at the system level, we need to have some sort of a ongoing training to people with lived experience around how to sit on committees, how to sit on boards, what are some of the, and self-advocacy and issues around advocacy. Because if you're experiencing your lived experience in the mental health system, it's a very, very important aspect. And to be at any table at the board level, that grounding experience of what it means to be somebody with lived experience and how you experience the system is very important. But we need to give people tools around providing them with training, and even maybe having, we use jargon. Somebody, I think it was Victoria who earlier said that we use a lot of professional jargon. Having those jargons, maybe a list of the most used, and explaining them and what they are, so that the person is not, it's not disadvantaged further by not understanding the language, and we remove as many barriers as possible for their involvement.
So it sounds like a lot of what you're describing now, Becca, and quite a few people, this is really resonating with them. Letitia, Khadija, and Michelle have all wanted to emphasize that they really agree with these points. You're really getting to, I think both you and Uppala are really getting to the basic concept of equity, which is that to ensure that people are able to participate at the same level, it's important to ensure that supports are in place, or that, for example, honoraria is offered in order to acknowledge that this is people's time, that they're contributing to sit at these tables. I just want to touch on Letitia's comment that often engaging people with lived experience can be a very emotional interaction versus a high-level education interaction, as we in support services need to be sensitive to the emotion attached to experiences. Sadly, from frontline experience, finds that sometimes government agencies don't always do this well, which can leave groups of the population feeling misunderstood and disengaged. So I think just pointing to the value of ensuring that when we engage with people with lived experience, we do so in a way that is, I think, sensitive and appropriate. So ensuring perhaps that there's a real opportunity for people to speak from a place of experience, but also that perhaps there is supports in place for that. So Khadija also talks about the importance of ensuring that there's training both ways, so not just for people with lived experience, but also for boards and for other organizations. And I just wanted, before we leave this topic, I just wanted to remind everyone that the third webinar in this series, or our last webinar, was all about lived experience and really focused on the lived experience of three women who themselves had experiences of migration and mental health issues. And they really talked about their current role now working as peer facilitators within the mental health system and also providing training to, exactly as Khadija said, the importance of training for both people working within the system. So that is the role that these individuals now have. So I really encourage everyone to go back and view the recording of that particular session, as I think it really does really speak to the importance of engaging people with lived experience. So perhaps we could move into our questions portion. I just want to encourage people to keep sharing their thoughts. We just have some time now before we end the session to ask if you do have any questions for Deqa or Uppala or myself, any just general questions about this topic, or if you'd like to share any more thoughts about how this work is happening in your current organization. I'd also like to encourage all of you at this time that you can access all of our previous sessions and this session as well at our Refugee Webinars page. So you can go there by typing in www.ontario.cmha.ca/refugeemh, and you'll find recordings of all of our previous sessions. So I think while we're just waiting for questions to come in, I'd really love to just hear from the two of you. Maybe, Uppala, I'm curious to hear of what some of the biggest challenges and some of the biggest rewards have been as you've tried to, because I know that you're someone that really brings a commitment to equity to all of your work. What have been some of the challenges in bringing that commitment with you as you do public policy and planning work when it comes to mental health? And what have been some of the best rewards of doing that?
Well, I think there's a ton of challenges. I mean, I think we're in a different place today in terms of equity issues than we were 10 years ago. I think there's a lot of recognition at a systems level, at an organizational level, of the importance of equity. Even things like, workplace diversity initiatives that have gained a lot of traction because people understand that it's actually better for the health of the organization to embed equity into all levels of planning and service delivery. So I think in a lot of ways we're very fortunate that there's been more and more research and the evidence base for why equity is important is growing because that means that we don't have to fight for the equity agenda at every opportunity. So I think it's been really great to see that trend over the last 10 years, that trend improve. I also think that it's been really great to have that governments are embracing this concept more and more at a national level, at a provincial level, and at a local level. And even if we think nationally in terms of our new government, equity, they've made a lot of commitments to equity, and even things as high level as gender equity and equity in terms of racial representation in the cabinet. I think these are all really great positive steps, and that really has a trickle-down effect at a very local level. So one of the really great pieces, which I forgot to mention earlier, is at the provincial government level, they've developed the Health Equity Impact Assessment Tool. And this is, I think we're in the third iteration now. And this is a decision support tool to help planning tables, systems level tables, as well as organizations with, thinking through when you're implementing a program change or a policy change, are there any negative unintended consequences of that change on people with marginalized groups? And we've seen across the province a trend in using this health equity impact assessment tool in various different forms. So I think that commitment to equity is growing. So I see that as a great, a positive step towards the equity journey in the province.
So Angela has just put in the link where you can access the HEIA, and I just want to emphasize that the HEIA is something that you can do both at the organizational level, but it's also something that you can use at a public policy or programs level. So it's a really great tool, and basically it's just applying an equity lens to any type of decision that you're making. You can also use it retrospectively, so if a program has already been in place, you can use the HEIA tool to check how you're doing with respect to reaching different populations. So definitely we're big supporters of that particular tool.
And I just want to add, too, that when government puts forward policy directives, you can actually use HEIA to filter that in terms of advocacy, right? So if you're a housing organization and you see new economic or social policy and you filter it through the HEIA lens, you might find that, hey, this new policy directive may have some unintended negative impacts, and you can use that as your basis for doing advocacy with government and working with government. So it's a really great tool that can be used in multiple different ways.
You can also use it in terms of funding, because if you can make a case that this is what we've done, and this is where the need is. You can make that case to any of your funding bodies. In terms of, I think somebody asked about Khadija, asked about OCAN. OCAN is for it's a ministry tool, Ministry of Health and Long-Term Care, and it's for organizations, community organizations that are working with community mental health. It hasn't gone to any other groups, but I think it's as a tool, and I'm guessing each funding area have their own tools, and I think the city-funded programs, they're developing a tool that could be similar to that.
So Khadija, I'm not sure if you're in the community mental health and addiction sector, but OCAN was really developed for that sector specifically. And if you want to find a tool, if you Google OCAN, you may come up to the CCIM website, and you should be able to find copies of the questionnaire there. I just want to pick up on Rochelle's question. She asked about examples of the HEIA tool being used at the policy level. So the Wellesley Institute has applied the HEIA for a number of different public policy issues. One were the cuts to interim federal health care that provides health care for refugees. So the Wellesley Institute used the HEIA to apply an equity lens to that particular policy decision, and they did another HEIA, I believe, to look at the proposal of a casino in Toronto. So at a municipal level, they also applied the HEIA to a public policy initiative. So if you check out the Wellesley Institute website, you should be able to find those examples. But I also just want to mention that CMHA Ontario is right now working to develop a mental health lens for the HEIA that will also help to make, I think, the HEIA in a mental health context a little more intuitive. But as Uppala said, one simple way to use the HEIA in a policy context is just to really ask how a particular policy decision is going to have potential unintended negative or positive impacts on specific populations. And that's something that we almost, I think, unintentionally do when we do all of our work at CMHA Ontario. When we're responding to a particular policy decision that has come out, that's really what we're doing, is we're looking at it to see how are people living with mental health issues going to be impacted by that particular decision. I'm just wondering if there's any more questions from our group, and while we're waiting for those questions to come in, I just want to quickly ask you, Deqa, what have been the biggest rewards of bringing equity into your work in service delivery?
Well, I would like to echo what Uppala said in terms of 10 years ago, or a little bit over, when I came into this sector, talking about immigrant and refugee mental health was, screaming at a wilderness. It was people used to actually push back and challenge and say that how is their mental health different than the rest of the population. Now, everywhere you look, at every organization, there's a statement or there's a focus around issues, and there's a recognition around health equity, importance of health equity. So that's been really one of the most rewarding things is looking at where it started in terms of me as a community mental health consultant at the time advocating for refugee and immigrant mental health, and now looking at the whole sector, that recognition. But also I think looking at health equities, the importance is, one of the most rewarding is when you work with people with lived experience closely, and you can see the change and the individual when you apply that health equity lens and work with them at that systematic level, that you can see the change and the empowerment, how that empowers the individual, and sort of that's very rewarding.
That's a very positive note, I think, to end our webinar on. So I just want to remind everyone to please complete the webinar evaluation survey. It really helps us to know what you like and what you think we can improve on with these sessions. We really do listen. I really do listen to all of the feedback that you've been sharing. And those of you that have followed us through all 4 sessions know that I've changed the sessions based on the feedback you share. So please do take a moment and follow the link there that Angela has copied into the chat box. I also want to thank Deqa and Uppala for sharing their time and awesome experience with all of us. I think it's been such a pleasure to hear from both of you about how you bring equity into the work that you're doing, and I certainly know that some of the participants have expressed that it's really helped them to think about what they're doing in their own work as well. I also really want to take a moment to thank Angela from EENet, who's been our awesome tech support, who's been managing all of the back end of the webinar. So thank you so much to Angela. And I want to thank all of you who participated. Thank you so much for listening in so carefully and for sharing all of your thoughts with us. For the first 3 sessions, I don't know the numbers for this session yet, but for the past 3 sessions, we've had over 500 people participate because of your passion and commitment to do your work better, to learn more about how you can better serve refugees and other marginalized populations. So I think that really picks up on what Deqa and Sheela have been saying about how things are really evolving within the system. And thank you so much for just participating in such an open way. And I will probably be sending you a note within the next couple weeks to let you know where you can view that webinar as well as the previous sessions. So I hope you do recommend this and the previous sessions to other people that you work with. And thank you again so much for everything that you do.